Good evening and welcome to the MyCP webinar. I'm Joyce Trost and I'm going to be your host for this evening. I am the Vice President for Research and Quality Improvement at the CP Research Network, and I'm excited to host. Tonight, we will have with us Liz Boyer, who is a clinical scientist at Gillette Children's, who will share findings of her study on falls in people with cerebral palsy called Consequences of Falls in Individuals with Cerebral Palsy. This presentation is based on data that was gathered in part from the MyCP Community Registry, where community members are able to self-report their experiences with cerebral palsy. And this study was designed to better understand how falls may be different over time as someone ages and how gross motor ability changes over time. So whether you go from walking to wheeling, et cetera. And members of the MyCP community who have lived experience helped to plan the study and participated in interpreting the results and planned for how that information would be shared. So the people who contributed to the data used in this study were ages 5 to 76 years old. And by using their gross motor function classification system, they all were able to walk with varying degrees of stability and needs and support. So they were GMFCS 1s to 3s. So Dr. Boyer's goal is to create clinically friendly fall risk screening and assessments, as well as interventions to prevent falls and teach safe falling techniques to help keep people physically active. Furthermore, Dr. Boyer hopes to help change physical and social environments to decrease fall risk and stigmatization. In this webinar, she will share what she has learned and so far and how the information she has gathered in getting her closer to achieving these goals. So the first thing I'm going to do is I am going to go through just an introduction of the CP Research Network, and then Liz will present to us, and then we will have time for questions at the end. So as many of you know, the CP Research Network was born out of an NIH meeting that our co-founders, Paul and Michelle, attended in 2014. And that meeting concluded that there were several important initiatives that needed to happen to improve the state of the science and treatment for cerebral palsy. First was the need for a national registry to capture patient characteristics, interventions, and outcomes for people with CP. And second was the need for more comparative effectiveness research, given the multitude of interventions that exist for people with CP. And this is an image of the yellow and green bubbles, which is from Iona Novak's famous Stoplights paper, which was published in 2020. And for many of these interventions, it's critical that we compare them within different populations to see really what is effective for each person with CP. A third objective was to increase the study of adults, given that most people in the United States living with cerebral palsy are adults, and that most of the research still focuses on children. And then the fourth objective was to plan a basic and translational research agenda to discover new treatments and preventions. And the fifth was to grow the field of researchers working in the area of cerebral palsy. And finally, the conference summary noted that the importance of engaging families in the journey and the research for cerebral palsy. So the CP Research Network was founded in 2015, shortly after this NIH meeting, with the mission to optimize the life and health and wellness of people with CP and their families through high quality research, education, and community programming. And so pictured here is the group of 45 people that were brought together in Chicago of 2017, and they were the ones that set this patient-centered research agenda called Research CP. This work was published in 2018 in this seminal paper. You can see our vision here. I'll give you just a few minutes to read it. And in summary, I would say that it's important to us to engage community of stakeholders and health systems in what we call a learning health network. So bringing people together to focus on improving health and well-being in ways that matter to people with cerebral palsy. So since the network was founded, we have made great progress in 3 pillars of education, research, and wellness. And on the education front, we've launched the CP Toolkit from diagnosis to understanding. We went on to release the Wellbeing Guide for Caregivers in 2017, and the Dystonia Toolkit then came out in 2024. And the Adult Toolkit, which was just released, can be found on our website or purchased on Amazon. We launched MyCP on our website in 2020, and we conduct monthly webinars just like this one to engage our community. On the research front, we launched our clinical registry in 2016, which now has over 18,000 patients in it. The community registry, which was launched in 2019, now has nearly 3,000 people in it. And we published our patient-centered research agenda initially in 2018, and then an additional research agenda for dystonia in 2020. In addition, we've launched over 6 quality improvement initiatives, all the way from early detection to pain evaluation in adults, truly covering the lifespan. We are academically focused with our work and have had 24 publications and more than 60 academic presentations. In the area of wellness, our website is a wealth of resources for cerebral palsy, and we are partnering with the National Center for Health, Physical Activity, and Disability, where we refer adults to well-being program called Mentor. And we work with NCPAD to develop a pediatric offering as well. It's a current project that we're doing. So we have 35 centers in our Learning Health Network, which are spread across the United States. And we have sites that are in the process of onboarding. We have sites that are contributing data. We have sites that are pediatric only, and other sites that are lifespan centers. So these are snapshots of what our clinical registry looks like. On the left, you'll see a graphic of the distribution of gross motor functional classification levels. So level 1 are individuals that are able to walk without assistance, and level 5 are those who are needing to use a wheelchair. So you can see the distribution that we have, and way over to the right, you'll see that we have a significant portion of our clinical registry where we are still missing this information. What we're currently working on is to get GMFCS levels assessed for every patient with cerebral palsy when they are at a clinical visit. So this is one of our goals for 2026, is to continue to decrease that level of missingness. On the right, you can see the distribution of ages. So along the bottom is where the age groups are. You can see in our clinical registry, most of our participants are between the ages of 6 and 25. So these 3 taller green bars in the middle. Now, in contrast, our community registry is slightly different. We have a little bit different distribution of GMFCS levels, with most being at GMFCS level 2. And our age distribution is significantly different, with most of our participants being adults or over 36 years old, as far as adults. So our strategy to stimulate research and quality improvement is really to help projects grow into funded grants that will bring about meaningful improvements to people with cerebral palsy. So we've taken steps to set a patient-centered research agenda. We've built an infrastructure that will be an advantage to researchers and clinicians in cerebral palsy. We balance between generating new evidence and improving outcomes through quality improvement. And we use the registry to monitor the implementation of evidence-based medicine and outcomes for the cerebral palsy population. So this next is an animation that I'm going to show you that shows the growth of the Cerebral Palsy Research Network research study pipeline. So the green dots are our quality improvement projects. The white dots are studies that are for children only. The red dots are for adults, and the gray dots are lifespan projects. So we're going to start in 2015. And then you can see we had just 2 projects going in 2015. We're going to move into 2016, 2017, 2018. You can see them moving across from the concept on the left to publication on the right. All of the steps that it takes to move a research study through our pipeline. You can see in 2020, we had a lot of quality improvement projects start up. They're moving through the pipeline. And then in 2023, we had another resurgence of new projects that were in the concept level. And as they have matured in 2024, they continue to move through study execution and into the manuscript writing phase. Now it's 2025, and you can see the busyness of our Learning Health Network. So the value of the CP Research Network really is unique. It has clinical and community registries. We implement a learning health network for cerebral palsy. We provide a platform for quality improvement and research through electronic medical record data extraction and a community registry. And we're really working to enable study on the long-term outcomes of individuals with cerebral palsy. And now I'm pleased to turn the microphone over to Liz Boyer, who is a researcher at Gillette Children's Hospital. She is an adjunct assistant professor in the Department of Orthopedic Surgery at the University of Minnesota. She is a rehab science graduate faculty at the University of Minnesota and has her PhD in kinesiology with an emphasis in biomechanics and motor control. I am going to stop sharing, Liz, and let you share your screen.
Thank you for the introduction, Joyce. Let's see if I can share with sound and get everything working.
Looks great.
All right, so, wonderful. So for those who may have visual impairment, I am a white woman, light brown hair. I'm wearing a dark green shirt, blurred background. And I also have the closed captionings on. I do know that, so that's intentional for those who may need them. So again, thank you to CPRN for helping me launch this study as well as giving me this opportunity to present. It is a follow-up. About 3 years ago, I presented some quantitative results. So you're welcome to go back and review some of those. I'll give a quick snippet of some of those highlights, but today we will be focusing more on the qualitative results and watch some wonderful videos and hear some great quotes from our members. And I do want to acknowledge that we are focusing on ambulatory individuals. We know those who use wheelchairs do fall as well. We're taking a staged approach to kind of tackle this bigger question around falls. So please reach out if you're a wheelchair user and passionate about this topic, and we can brainstorm how we can do more research in the future in that area. So I want to thank from left to right, Marissa, Carrie, Sandy, Nate, and Linda for being my co-authors on this project, and other individuals who helped me plan this study. Funding came from our endowed fund at Gillette, so thank you to those donors. CPRN helped recruit particularly the adults for this study, and as you'll see, I borrowed some photos from their adult CP toolkit. I've used some photos from iStock, and I even played with some AI voice generation, so hopefully you enjoy that. But also a huge thank you to the participants because they help us and enable research to happen so that we can provide, objective data behind, defining the problem so that we can hopefully go on and get those grants that Joyce alluded to solve and design even better studies. So tonight's outline, we're going to look briefly at the why, the how, and the what some of our results showed. Both of these studies have been published. On the left, the quantitative results, and on the right, the qualitative results. The study on the right, anyway, is free for everyone to access right now. So please take advantage of that and always reach out if you have further questions after you read more. So the why. I started at Gillette as a postdoc fellow in the Gait Lab, and we saw and heard people talking about falls. One of our intake questions asks, what are your particular concerns regarding the patients walking, falling, or constant anxiety about falling, or balance were frequently mentioned. So in 2018, towards the end of my postdoc, I started working with a summer research intern, and we had some data in our Gait Lab, and we wanted to see how frequently are people falling. And frequency was reported from never to more than once per day. And we were able to discover that those in GMSDS level 2 reported the highest frequency of falling. And as you can see in black is never, for instance, and most individuals in GMSDS level 4 reported never due to constant supervision, but you can see that some individuals do fall. So we had, for the first time, some objective data looking at fall frequency in children by GMSDS level and found that falls are really common. We also started gathering the Gait Outcome Assessment questionnaire for our clinical patients. And I love this questionnaire because it asks, is this your goal to improve? And on the left, you can see some examples like walking with feet flat on the ground, walking taller or in less crouch. But you also can see this item, walking without tripping and falling. And among over 300 individuals, we found that walking without tripping and falling ranked #1 out of all 49 items on the goal. And my colleague Megan, a couple years later, repeated that study with a larger sample size of over 600 children, and still walking without tripping and falling remained as the #1 very important item. We saw the parents' concerns about falling. Subjectively, parents perceive walking to limit their child's ability the most compared to other factors such as endurance, weakness, safety, pain, or mental ability. And this is an example in GMSDS level 2, but we also have the other ambulatory groups. So those warmer red, orange, yellow colors indicate that people are reporting balance in these factors to limit their walking at least half the time, if not always. So those are some objective data. You can find almost anything online. I came across this TEDx talk, which I grabbed a snippet from. So I want to share some of Matthew Struder's comments regarding falls. And hopefully the audio works.
So I mentioned I know this because I fail a ton. That's because I have, and there's no greater parallel to failing in life than actually falling down. I mean, physically falling down. See, the reality is, when somebody with CP, we fall all the time, unless you're in a wheelchair, and we get really good at it. But when you take an able-bodied adult, when we fall over, our natural instinct is to get up as quick as we can and, oh, that didn't happen. Why do we do that? Usually it's shame, it's embarrassment, because we're expecting, we're not supposed to fall over anymore. We're grown adults. And that's our problem, is our expectation is just that.
I love that commentary from Matthew because he talks a lot about those psychosocial effects and things that I didn't always think about, quite honestly, because I was thinking about falls from the literature and they report, mortality and other things for older adults. And so I really was taking more of that healthcare medical perspective of, we should be most concerned about injuries. But as he showed, and you'll hear more, that it's more than just that. So there's also some of those same sentiments captured in the literature. This was a study looking at adults with CP ages 30 to 65. And again, the most frequent self-reported cause of functional decline was reduced balance. And there have been adult and adolescent qualitative studies where we've gotten some wonderful quotes and other experiences from people talking about how it's more embarrassing and scarier to fall with increasing age, and downhills are a big concern, and falling in the home isn't as big of a deal as outdoors because in the home there's often things to grab onto to help get back up. Crowded places can be scary and avoided, and people can be reluctant to go out. And then the use of walking aids can also help with balance and energy conservation concerns. So those are some of the themes for the adults. And this was another study that really kind of influenced me as I was designing my bigger study, was this study of 8 adolescents with CP. And they suggested that GMSCS level 1 to 2 were more concerned about balance and falls than level 3. Embarrassment and frustration seemed to be more common than fear. I love this quote from one of the 17-year-olds in the study. I fell in front of the bleacher full of people. I was like, oh no. But yeah, in general, that's also why I don't participate in school sports. And so that got at activity avoidance. But their study also identified how we can provide different social factors like adaptive equipment or positive coaching, activity modification, and adapting these kind of more external factors can really help and encourage people to continue participating. And so those were kind of at the center of how I designed some of the questions, in addition to my conversations with young adults and middle and older adults as I was designing the study. So what we didn't have really was a whole lot of objective data looking in depth more at those physical and psychological causes and consequences of falls in both kids and adults when I started this study. So that was one of our goals. And we are also seeing hints of differences by age and GMSCS level. So that's why I really wanted to take that lifespan approach with this study. So some of the highlights of the quantitative study: we recruited primarily through email of Gillette patients, also some face group posts, and of course MyCP through CPRN. We had 381 participants, ages 5 to 76, and we did have slightly more GMSCS level 2s. Everyone answered online surveys. So looking at what proportion of individuals reported a fall in the past 12 months. On that horizontal x-axis are the different age groups, and the 3 different colors are the 3 different GMSCS levels. Compared to ambulatory individuals, to the older adult population, individuals with CP were about 2 to 3 times more likely to report a fall. What's more, the median number of falls in the past year across this entire group was 6 falls per year. So not only are they falling at least once, they're falling in general more than once. Furthermore, one of my favorite statistics from the study is that 88% of individuals wish they fell less. Putting the frequency or proportion of fallers into perspective, you can compare that to, in gray, our older adults, 65 or older, and those with multiple sclerosis, stroke, Parkinson's disease, amputees, and incomplete spinal cord injuries. And our adults, 83% of them reported a fall in the past year. So by comparison, this is presumably a larger concern for these individuals. Serious injuries that required hospitalization or medical care included injuries such as stitches to the face, fractures, sprains, and concussions. And the graph on the right shows, as you imagine, as you get older, you have more time to experience a fall-related injury. But in that oldest group, 50 or older, about 50, or almost 70 to about 90% of individuals have reported a serious fall-related injury. We looked at some of those emotional or psychosocial factors. So concern about falling and avoidance behavior due to concern. These were measured with a 7-question survey of very patient-centric activities. So what is your concern or avoidance around dressing, bathing, getting in and out of a chair, reaching above or below for an object, going up and down stairs or slopes, and then going out in public? For the concern, individuals selected between 1, not a concern at all, or 4, very concerned. And a similar 4-point scale was used for avoidance. So those 7 items were summed, so a max score of 28. What we observed was that oldest group, 50 or older, reported the greatest concern and avoidance. Furthermore, individuals in GMSCS level 3 were greater than 2s, were greater than 1s. So there are differences by age and GMSCS level that we need to be aware of. The 2 activities that tended to have the greatest concern and avoidance were stairs and slopes. All right, so the main focus, looking at the qualitative study results. We created an infographic as shown here for that journal publication. So I'm going to use that to walk us through some of our study. So again, the purpose was really to look more qualitative, like gather the lived experiences around falls as they relate to causes, adaptations, and psychosocial impacts and solutions for a safer environment. 316 individuals, approximately equal number of caregivers and adults, answered 4 open-ended prompts or questions. They included, feel free to share any more information regarding clarifications on the consequences of falls, how you have adapted to avoid falls, clarifications regarding balanced confidence and activity avoidance, and then any other comments, including what society, clinicians, families, or society can do differently to make physical and social environments safer or decrease your concerns about falls. This briefly summarizes those qualitative methods, but in short, we had kind of preconceived notions based on the literature and conversations about what themes might arise, and then inductive approaches where we're letting the data talk for itself. 2 individuals independently coded that, and we worked with our 3 people with lived experience to help inform our code book and reach consensus on disagreements. So there was 2 big themes that emerged. So internal factors and external factors. And those 4 sub-themes under each include psychological or mental, physical, avoidance, and adaptation. And under external, we have people, environment, policy, and healthcare. And oftentimes examples were given kind of from a cause or effect perspective, so you'll see that show up. And many of the quotes that I'll be sharing today come from supporting information. So if you access the actual article, you'll have to dive into the supporting information for additional quotes. So this table just kind of provides a count or that content analysis of those 4 different internal factors across the 4 different questions. And when it comes to avoidance, we broke that further down into public, physical exertion or physical activity, and terrain. And then adaptation is broken down into physical or psychological adaptation. For external factors, the 4 examples are shown here, along with their respective counts. So to kick us off, sometimes people's comments crossed multiple themes, and sometimes their quotes were so good I didn't want to break them up. So we're going to start with some of those themes right now and some of the AI voice generations I played with.
Falling is part of having cerebral palsy, but the severity of my injuries grew as I reached middle age, and my muscles naturally shortened as well. I've always fallen often, but I got by with mostly bruises and scrapes until after age 35. People also assume I'm not intelligent because of my falls, yet I have a high IQ. However, the most difficult part for me of falling is the loss of confidence in my physical abilities.
So what we
Falling is
heard-
part of having cerebral palsy, but I got by.
What we heard over and over, this quote and others, is to help remove the stigma. Physical impairments do not equal intellectual impairments. Here's another from a 40-year-old.
It is never a good feeling to fall. When I was younger, I would get up really fast and usually be able to brush it off and keep moving. For the most part, that is what I still do. However, I have noticed that as I am getting older, it is harder to just bounce back and keep going. It is getting harder to get up without something to hang on to. I worry more about falling than I ever have before. I intentionally make choices to avoid falls. I also sometimes feel angry that I have to deal with this in the first place. I have also noticed that when wearing certain shoes, I am more prone to falling. Sometimes it makes me angry that I cannot just wear cute shoes. It sounds silly, but it can be frustrating. I have sent very cute shoes to the Goodwill after falling. I have 2 toddlers, and they leave toys all over the floor at my house. I am constantly picking up toys and trying to keep my path clear. I feel like since I had kids, I do fall more because there are more obstacles in my path.
So many factors she brought up, but you can see examples of different footwear choices as being some quick fixes that she has
It is never a good.
acknowledged. Here's another 24-year-old.
Although the questionnaire focuses on falls, I have almost daily tripping episodes where I catch my toe on nothing and have to stumble to catch myself. I have run into door frames, desks, coffee tables, etc. because of this. I hate the concerned gasp and, "Oh my God, are you okay?" response I often get from people who witness my fall or trip. I will tell you if I'm not okay. Just let me get on with my day without treating me like a small child. Honestly, my biggest struggle is winter because of all the snow and ice. My life would be easier if cities made sure sidewalks and roads were plowed and salted. I have taken time off from work in winter to avoid the risk of a fall due to ice or snow.
2 key things I really want to point out here. A reaction was mentioned over and over, and how people want that autonomy, and you'll hear that later from Carrie as well as the taking time off work. I think if employers would hear that more, they would pay more attention to
Although
the
the
severity of
questionnaire-
this problem. And lastly, or not lastly, next
Where
one.
does one begin? There is a real lack of information/research about the impact of aging on pre-existing disability and the value and type of exercise. Our current health insurance system limits the amount chart length of physical therapy services, which I have found to be very beneficial. Although we have made significant public policy advancements, societal and, yes, family attitudes continue to marginalize and place low expectations on persons with disabilities. The COVID pandemic has starkly illustrated the degree to which we as a nation devalue persons with disabilities and our aging population. Programs and services designed to benefit those of us with disabilities have been severely curtailed, and the lost benefits may never be recovered. Perhaps folks like myself with a secure income, good education, and a sophisticated support network will persevere. But these assets, including good healthcare and insurance, do not offset my daily concerns relative to the increased likelihood that a serious fall may soon have a very negative impact on my daily living. Where does
And as we transition to a few more specific internal topics, here's a 54-year-old female.
I try to do risky things with optimal mental awareness and as slowly as possible in case I have to change my approach or adaptation midstream. Optimal mental acuity and muscle strength and tone is key for me, which is one reason I stay away from muscle relaxants. I live alone, so if I lose my ability to anticipate things and think things through in risky or potentially risky situations, I'm screwed. However, for me, now that I'm older, most of the danger in falling is the difficulty and expenditure of energy and time in getting up off the floor. I try to do
Right, so we'll go through a few more specific examples. Mental fatigue and being distracted was an overwhelming cause of the majority of this individual's falls. If I'm not thinking enough to pick up my foot, bam. A 62-year-old. In order for me to stop falling as much, I have to concentrate really hard, because if I start thinking of something else, I fall. Sometimes I cross my feet in front of each other, then I fall, like I did the other day. 35-year-old. I think fear and anxiety around falling contribute a lot to my inability to balance when performing some activities. The older I get, the less confident I am, and the slower my reaction times become. Some effects. There is themes of resilience that came through. Here's a wonderful example. At age 54, I have no time for embarrassment. I am an expert faller. 10-year-old parent. My son is self-motivated and has the passion and desire to walk. Even when he falls, he will get up by himself and continue his training. However, he gets upset a few times when people are around. This gives me the impression that he does not like others to see him fall. This was a very profound quote. Sometimes I worry more about their reaction, even before thinking about any pain. I worry people will see my falls and worry I shouldn't be independent. I worry they will stop seeing me as an equal and more as a liability. 36-year-old female, GMSCS level 2. I am more concerned about the embarrassment of falling rather than the potential physical damage. And it depends if falls occur at home, work, or public place. Falls at work are the most difficult. 69-year-old female. I don't want to be a burden to anyone. These are really heavy concepts. And now I'm going to give you a snippet of our podcast related to this publication with Marissa, Nate, and Carrie. They did a fantastic job. So we'll start with Nate.
To lift. I've lived with a fear of falling since middle school. When I first noticed my fear of falling, the worst part of it was if someone saw me fall. In more recent years, even walking to work without fear of falling could be a major challenge. When my fear of falling was at its worst, I felt like all I did was go to work, come home, and do physical therapy. I shut many of my friends out because I did not want them to see me struggle. I was very stubborn about not using an assistive device to help me walk. In my mind, fear of falling and fear of physical decline are closely related. The advice I would give my younger self: if using an assistive device to help you walk keeps you safer and adds to your quality of life, use it.
Some other causes. Individuals often mention there can be more than one cause. For instance, uneven surfaces and muscle fatigue. Other individuals cited startle reflex or epilepsy as causes of their falls, and as we'll see later, vision problems. I get nervous when my muscle tense up, and it takes a bit for them to calm down. 59-year-old. As a senior, falls are more fearful now. That fear will also tighten up the body, which increases the likelihood of falling. You worry more about injuries. As a younger person, you got up quickly so no one would see you, shook it off. Now, if I fall, I may need help to get up or have to crawl to some piece of furniture. It decreases independence. This 56-year-old female, GMSCS level 1, shared that they haven't had any fractures yet, but they have osteopenia, so they're very aware this time may come. 32-year-old share that they often fall forward and have broken their kneecap twice. Some other effects. This 61-year-old reports their first major fall was at age 2. They broke their nose, had a concussion. Then they began ice skating lessons, which helped. Recently, as an adult, my falls have started again due to vision problems and my right leg collapsing. Major traumatic injuries resulted, and I've had surgeries or wear casts after each of them. They're doing neuro-PT, and here, as you see, worry about the underlying lurking CVI or cortical visual impairment. This 59-year-old female, GMSCS level 1, reports 4 fractures, 2 in her spine and twice for her 8th rib. She's fallen in the bathroom and it ended up fracturing all 8 fingers. I have arthritis in my SI joint because I keep falling on it, but more on the left side. It's hard for me to use any type of walking aid because I need to have a hand free for walking. It's either I walk or succumb to a wheelchair. I refuse to do that until absolutely necessary. This 54-year-old. I've noticed since turning 40 that my body doesn't bounce back like it did. I've had 2 temporary admissions, 6 weeks total, at 2 different care facilities until they deemed I was safe to return home. Avoidance. Sometimes I just sit there and watch everyone else have fun because I hate my disease. 16-year-old female. It lowers confidence, increases fear, and does not want to go out and access life as a result, especially after a hard fall. 14-year-old female. I have fairly significant anxiety in large crowds as a direct result of the falls I've experienced and the subsequent fear of falling or being knocked over. 34-year-old. Here are some examples of physical activity avoidance. My child will avoid sporting activities and other youth events because of the possibility he could fall. He's quit soccer because of this, dreads school track and field day, etc. 8-year-old. Due to my recent circumstances of my walking getting worse, I have to avoid many activities altogether. 30-year-old. And here's a 29-year-old. That also speaks to adaptation at the start. I always have my partner home when I take a shower in case of slips and falls. I never left anything over my head and frequently ask for assistance if something's out of my reach. I don't engage in sports of any kind. And I usually have someone accompany me during outings. People often reported avoiding different type of terrains, especially slopes and stairs. Here's another example. I love this quote. Reaching for stuff above my head is okay. Reaching stuff on the floor is sometimes hard. So I have a grab stick. Walking up slopes is okay. Walking down can be problematic because of my balance. I say that I love this quote because it can inform a modification to that standardized survey we used before that groups reaching above and below the head into the same item. But this suggests that there's a clear difference and that those items should not be combined. Here's an example of some caregiver or parent prompting that has influenced their child's behavior. Usually if he feels unbalanced, he'll voluntarily fall, so the fall hurts less. I would say most of his falls are because he feels a fall is coming, so instead of trying to catch or correct himself, he chooses to fall at his own pace. And we have taught him to sit down when he's unsteady. He only does this because of repetitive instruction, not out of fear. And then the 6-year-old reports, fortunately, I have learned how to take a fall so that I can hopefully prevent major injuries. And there are some martial arts techniques that study that. And therapy and strength training, balance training were common, such as from this 17-year-old male. Adaptations include sitting while showering or getting dressed. A 34-year-old individual shares, I still do the activities, but I use a wheelchair to do so. Without the wheelchair, I'd avoid most public activities. Crawling can also be a very safe option for people. And this 12-year-old, I have to use a walker at school to keep kids from bumping me and making me fall, even though I can walk well with a stick and hate using the walker. Parent of a 6-year-old, they do not avoid activities that causes falling unless he has fallen and is still hurting. He is willing to do or try anything physical. This 32-year-old reports psyching herself up, but if it's too hard, she'll ask for help. Many themes covered here, but this 23-year-old reports going with people she trusts, having a plan, and wearing braces and getting enough sleep. So some of our external factors briefly, again, we had kind of 4 domains: people, environment, policy, and healthcare. So for this, I'm going to share some of Carrie's portion of the podcast.
Their falls.
Carrie, you've mentioned your favorite finding from our research was the request to let the faller decide if they wanted help or how they wanted help given after a fall. Can you share specific details?
This is my favorite finding, and I'm so excited to talk about it. You know, waiting to help when someone falls near you isn't always easy. But let the person who's fallen decide what help they want, or if they want any help at all. Fallers need to reestablish autonomy over their own bodies, and many of us have experienced how scary it can feel to have someone grab you or pick you up, especially by a stranger. We also might need time for our muscles to be ready to stand or to assess if we have a serious injury. Well-meaning bystanders tend to want to rush the process of getting him back up because culturally, I think we feel like the person is okay once they can stand again. But the faller actually needs bystanders to be patient and give them control over what help they accept. Maybe somebody just wants you to stand by while they try to get up on their own, or use your hand or knee as something to pull up on, or be willing to call 911 or go for help if needed. Chris, I also want to underscore something you mentioned in your intro about
to see more, these are on DMCN's YouTube channel, so please take a
The
listen. They're
lesser-known
freely available. But those are such important factors that you'll see come through here. And here's some specific quotes leading to some of those recommendations that Carrie covered. Another 34-year-old female, GMSS level 2. Do not make us feel bad about falling. Let us be in control of how we feel safe in any given situation. Don't make us feel bad about the equipment we have or make us feel more like a burden. Very common comment. Want to really emphasize this one. Please don't rush me. At least a quarter of my falls happen when I'm rushing myself or feel as if I'm being rushed by someone and I'm trying to hurry to keep up with their expectations. This is about changing expectations of society, right? A big public service announcement. It should be taught that it is ableist to have people remove their shoes when entering your house. Educate other children about CP so they continue to have an understanding of the condition and impact on other children. We have to find a way as kids expect my child to be as fast at playing sports and tag. They get frustrated and say challenging things to my child about being slow. Another very common quote, get rid of scatter rugs. One of the quotes, quote, burn all rugs forever. Rugs are evil pieces of trash. Okay, I think we all can agree with that. Maybe cute, but not very functional. Shovel sidewalks, curb cuts, and crossways. And of course, we all don't live in winter. So I was very thankful for this quote from someone from Arizona. In the summertime here in Arizona, falls outside are especially dangerous because the ground is so hot and burns. It takes time for me to get up or for someone to help me get up. Other environmental considerations. Have better lighting, automatic doors, and level surfaces for eating establishments. Love this one too. Have the bathroom handicap stall at the entry of the bathroom, not at the back. I wish more stores had benches to sit on when shopping, and I avoid restaurants that only have high bar stool type chairs as they're extremely hard for me to get in and out of. Also, many hospitals and doctor offices have long distances to walk in order to receive services. Benches along the hallways would be very helpful. I don't want to use a wheelchair, or I don't use a wheelchair and don't want to. Little stops along the way would be a great help. Fix uneven sidewalks more regularly. Replace street curbs and install handrails on slope sidewalks. And stairs was mentioned. 2 handrails, 1 on each side, was also repeatedly called out. And if there are handrails, there is a specific quote asking people to not put decorations around them. Design less areas with slopes and try not to make stairs as steep. Shallower stairs are easier to prevent the fear of falling. From a policy level, the world is not made to accommodate people with special needs, regardless of the Americans with Disabilities Act. Have Medicare allowed wheelchairs for longer and more likely to fall trips outside the home. Make parks, trails, stores, museums more accessible and fundraise for more of those adaptation features. Specific to healthcare, 12-year-old, I need more regular PT. I fall less when I have PT, at least twice a week. Balance training really helps. 28-year-old female, PT has been helpful, but doing something in a controlled context is different than being out in the community. It would be great if PTs could incorporate being outside into sessions. Kind of overwhelming agreement also on this item, allow for PT and OT throughout one's life. We heard earlier some people shared that they've learned to fall safely. Other people were calling for that specific training. So I would love more training on how to fall safely or prevent falls from a 54-year-old. And then this one was from a parent. It would be great to teach kids how to fall in a way that minimizes injuries. There are some treatment-specific comments. This is an example. Post-SDR, or selective dorsal rhizotomy, my biggest challenge is numbness. I still can't feel the bottom of my right foot, so I haven't done anything physically intense because I'm afraid of losing my balance. An individual who lives on a farm. Because I have poor balance and the terrain is more difficult, I need adaptive equipment that's better able to hold up to the rough farm terrain. One quote here focused on patient education. Please stop providing patients with lifelong disabilities the same fall risk advice you provide to elderly patients. Falling is simply a risk of me living in my body. I'm already doing everything I can to prevent falls without seriously limiting my own abilities to live the kind of life I want. Fall risk patient education is, for me, one of my biggest pet peeves. I'm already doing everything I can. As for clinicians, please validate my experience and help me find ways to do things I want to do. These are showcasing some of the wonderful pictures from the CPRN Adult Toolkit. Dr. Linda Kroc was one of our co-authors, and she shared the importance of making fall concerns a point of conversation. She says, it appears some of the people with CP that we see in clinic minimize their fall experiences or just don't mention falls as they have come to see it as part of their CP. It's important for them to share this information. Perhaps therapy or other interventions should be considered, and that wouldn't be part of the recommended care plan if we don't have that information. So taking us home here, we saw some of those key findings about the emotions, the embarrassment, activity avoidance, and how that seems to be greater concern than some of those physical injuries. It's not just about falling, but also getting back up. And we also really need to acknowledge and emphasize autonomy as individuals navigate falls. Sports and physical activity can be avoided. People may miss work because of falls or fall concern. But people also demonstrate much resilience in sharing many of their adaptation strategies. Healthcare, as we just wrapped up with, has opportunities for improvement, especially as we plan interventions. And space recommendations include more handrails, shallower slopes, wider curb cuts, more benches, and clearer aisles. So in conclusion, many of the factors raised throughout this study were multifactorial. So we have to take that multidimensional perspective to come up with solutions that might span the individual to policy levels. And don't think that these are too expensive to fix. As we mentioned, some are those simple low-cost fixes that we can help make environments safer. And so we really need more ongoing discussion, which I hope some of you will engage with, even though we're wrapping up at the end of our hour. And more research will really help and be the crucial next steps to reduce falls, injuries, and mental and social effects. References, and happy to discuss.
Thank you so much, Liz. Those were some very great quotes to give good insight into this whole topic. And I've loved watching the chat, people talking about their experiences with falls. And so, Liz, I hope you have a chance to catch up on that. We'll try to, I think I can save it and download it so you can see those comments. That would be
Thank
really
you.
good. Yeah. June did have a question. Is it more of a challenge to teach an older person with cerebral palsy to fall due to fear of an injury? I'm guessing she's comparing it to somebody without cerebral palsy.
Yeah, June, I'm not sure. I don't know if it's really been attempted. I know some of the research in older adults that they've tried, they've excluded people who have like low bone density, so where fracture might be more of a concern. I don't know if they screen for kind of fear of falling or anxiety that way.
Yeah, I was just focusing on people with CP. It seems when we're younger, we're more fearless. We just, oh, what that,
Yeah,
do it. But
yeah,
you get older, there's more of a hesitancy and fear. But I was just
yeah.
talking about people with CP, not just the older population.
Yeah, correct. I'm just saying, like if we try to borrow what some other areas have tried to do and explore, I think that's why I don't think we can just use that recipe and guidebook and just apply it. I think we'd have to clearly adapt it. And that's why, maybe it is, we really need to start younger so that we don't have that cumulative effect of injuries or fear.
Mhm.
But talk to me more as we
Yeah, thanks.
Christine has a question for you, Liz. Oops, it looks like Liz
Yeah.
just froze.
Hi, Liz. I really appreciate your talk. I was wondering, most of us with CP have had a gait study when we were younger that was used maybe for specific purposes related to surgical planning and post-operative care. Could you see a potential role for something like a gait study to be a predictor of likelihood of falls?
Oops.
Sorry, I think my internet closed on me.
We're gonna let Liz get back on her phone. I think is that what you're trying to do? Or no? Yeah, okay.
Did you hear my question?
There we go. Liz, did you hear Christine's
I'm
question?
sorry, I didn't. It froze.
Okay, Christine, you want to ask again?
Sure. I said most of us with CP have had a gait analysis study at some point in our life, often pre-surgical and post-surgical type testing. Could you see a role for gait studies in being able to determine uh, potential likelihood of falls based on how much pressure someone's putting down when they walk and those sorts of things?
We have different variables, in our gait lab that look at plantar pressures underneath the feet. We could explore. But yeah, hopefully I can take more time and look at more of the data, but we don't have kind of the greatest outcome. It's kind of like I shared at the beginning, did you fall once a month or once a year or something like that. So, but definitely something worth looking at. So we can talk more in detail when we connect, Chris.
Liz, this is Debbie Thorpe.
Hi, Debbie.
Hi. My PhD student, for her dissertation, did a study, and we used a instrumented treadmill with a harness system. And we had adults with CP come in and walk on it. And we instrumented it to trip and slip them. And so they practiced over 12 weeks with trips and slips. And by the end, they weren't even reacting to the trips and slips. They were actually adjusting on their own with no pressure on the harness. So I think adults with CP can be trained, to improve their balance. I mean, we've kind of shown that. We published the study. So Alana Levin, Levin, would be the primary author on that study.
Yeah, I've cited that study when I tried to put in a grant to do a similar intervention
Did you?
study.
Okay.
Yeah,
It was pretty amazing because
yeah.
we had ones and twos come in, and the twos, especially in the beginning, were very jittery, very nervous. We had the harness system, and they relied on the harness system a lot. But by the end of the 12 weeks, they came in twice a week. And by the end of the 12 weeks, they were just walking along. And I mean, we would slip them and trip them with the treadmill stopping or starting. And they just, I mean, you couldn't even tell hardly at all in the instrumentation that they were missing a beat. And their confidence just really, and anecdotally, their function increased. They were walking longer distances. They had more endurance. So I think adults, they definitely can be trained.
Yeah, those are so exciting. And I would love to do that at scale. So
Yeah.
reach out. I
I'd
don't
love for
know.
you to do that.
Yeah, I know, it's a challenge because
Oh, I know. I
funders say,
know.
well, you don't have experience doing that. It's like, well, I know, but I'm partnering with someone who's done it. And so, so it's that battle. But yes, I really think that reactive training, that reactive balance training is absolute key. So
Yes.
yeah, that's the route I would love to go.
Well, is that just research or is that being used to help real people? Like, or was that just to publish a study?
That was just a published study. Yeah.
So
I
then
mean,
what's the point? Because I'm a physician and I'm 50 and I've fought so hard in medicine. Like I'm basically not working. I think just because people don't like that I'm slower, so now I'm working nights and it's just like, I like it because I'm basically by myself but that isn't right. Like society is just really not very inclusive. And that's what I'm curious with all this research. Like, I feel like people just keep publishing papers, but what's the plan to like put it back to people?
Well, you're absolutely right. It takes funding and money, and to get third-party payers to pay for that kind of intervention, you need large-scale studies, and it's extremely hard to recruit, and it's extremely hard. The equipment that Liz and I use is extremely expensive, and so to get funding to do that, like she said, she put in a grant. And right now, grants aren't really getting funded. So, it's, I think physical therapists who read that literature could try that in their own clinics. Not a lot of them have split bed treadmills that can stop one side and start the other side to slip and trip. But definitely you could walk on a treadmill, speed it up, slow it down, speed it up, slow it down, and still get the same kind of reactions.
And what are the age groups that you studied again?
We had 21 to I think 71. There was a 71-year-old man in our study.
I don't want to take up too much more time, but that definitely seems useful because for me, like ever since about the age of 29, once I graduated medical school, I've run into trouble. And I feel like my function declined because I kept being let go, quote unquote, from work. It's hard I just wonder like how much of this is that I'm not like a part of society like I was versus aging. But it certainly seems like with that you definitely could increase function because I'm dealing with a lot of flack from my family because I just moved back there for 20 years. And so they're not used to like I need help outside and they just think it's all, oh, you're not doing enough on your own. And it's just like, I don't, it's hard to know whether it really, are you going to blame me or is it just, but clearly it seems like your research proves that you can regain the function. It seems like it'd be very useful to me.
Yeah.
If you can, so it's 10 after, we should probably let Liz go.
Okay.
But if people have questions and want the reference to the articles, you can email info@cprn.org. I put it in the chat. And we can give you the reference for Liz's blogs or blog posts and the article that's free and then the article that Debbie was talking about. And you can take that to your care providers.
Well, that's
That would be a great way to start, either to your physician or to your physical therapist that you're working with. That could be very helpful in their treatment. So thank you everybody so much for coming tonight. We really appreciate it. Liz, thank you for a very, just a fantastic talk. And if anybody here has not joined MyCP, we would encourage you to go onto our website and do that and fill out our questionnaires. All right, have a great evening. Thank you.
Bye, everyone. Thank you.